Hello, I'm Alan Johnson. I'm an occupational therapist, and we're here today to talk about accurately coding late loss ADLs. Okay, so this is an open discussion, so if you guys want to ask questions, feel free. I would like to be able to answer any questions that you have. Oftentimes we go through this training and there's things that come up that either you're not familiar with or it's different than the way that you're currently doing it. So, if you need to ask clarifying questions, we can do that. So, this program is called BETI, and that's an acronym for the late loss ADLs: bed mobility, eating, transfers, and toilet use. And we added a Y and said, yes, you coded BETI correctly, so that we could call it BETI. Yes.
What does late loss ADL mean?
That is on the MDS. There is a set of ADLs that we score that are considered the crucial ADLs that typically a long-term care patient or a skilled patient may have trouble with, and they tie back into scoring of the rug level, and they score the end split of the rug level, the ADL end split.
What's a rug level?
Rug level is based on the MDS. It places a patient into a resource utilization group, which is a compilation of all of the care needs of that patient based on what the MDS has collected.
So why would that be important to me?
Okay, well that's what we're going to discuss
You're going to tell
today.
us later?
We're going to talk about that right
Awesome.
now. So the objectives of this program today are to provide an enhanced understanding and importance of bed mobility, eating, transfers, and toilet use, provide the definitions of self-performance and ADL support provided, learn some important coding tips, review examples of setup help for support provided, talk about the definitions of each of the ADL areas, review some common coding areas, best practices to improve coding, and then we're going to review the use of the BETI reference manual and with some specific examples. Okay? So, why is this so important? That was the question. It's extremely important that we most accurately code what the patient is able to perform in regards to ADLs and how much support we're providing. Because based on what we report, it applies a case mix index score to that rug level on the MDS. So then that ties back into the ADL end split that we referenced, and will then tie into a per diem reimbursement for that patient based on what we've provided and what the patient's capable of.
So that means that it affects how much we get paid
Correct.
for that person's care?
Correct.
Okay.
So that's why we want to accurately account for it. The other thing that is very important about accurately coding ADLs is for compliance reasons. So if we're inaccurately reporting what the patient's capable of or what we're providing in terms of support, then that's going to go into the MDS, and the MDS will be inaccurate when we submit that to the state. The state surveyors will come in, they'll review the documentation, they'll look at the care of the patient, they'll look at the MDS, and if things aren't matching, then that could leave opportunity for citations based on care. Another key component of reporting accurately is for the patient's safety and for your safety as the caregivers, as the staff members. Because if we're reporting inaccurately, then the care plan won't be accurate, and then you won't have the information that you need when you're going in to work with the patients, and you may be unprepared to do what that patient needs. And also, if we're not reporting accurately, if the patient starts to show changes in their needs or their abilities, then we won't be able to update the care plan accordingly. So it's very important that what we're reporting is as accurate as possible for reimbursement, for compliance, for patient safety, and for caregiver safety. Okay? Any questions about those things? Okay, great. All right, so there's two areas of coding. There's self-performance and support provided. Self-performance is what the patient actually did, and support provided is the amount of staff that is needed to assist with the self-performance. So let's define first self-performance. And in self-performance, there's a number code, and then there's the definition code. So how are you guys currently reporting it?
Like that.
Like that, with the numbers?
Yes.
Okay, great. So, as we go through these definitions, what I like to reference is the threshold between each of these and what qualifies for the next level of self-performance. So when a patient is independent, that means that they need no staff help, no staff oversight. They don't need anything. They're able to do it all for themselves. So that means we're not in the room. We're not even there. So an example would be you walk in and you say, okay, Miss Betty, it's time to get up and come out and have breakfast. Then you leave the room. And then 15 minutes later, Miss Betty comes out and she's dressed, her hair is combed, her face is washed. She's ready to go for the day, and she comes out and has breakfast. We can confidently say that she did her ADLs independently and without any staff oversight. So the next level, supervision, the threshold is if we walk into the room and we put our eyes on Betty and we're present while she's doing these ADLs, then that would be considered oversight, encouragement, and cueing. So just putting our eyes on her is oversight. Our presence is encouragement because she can be more confident. She feels like she's got somebody there to help her if she needs it. So you would consider that to be encouragement. And then if we give her verbal instructions or even going into physical cueing, then that would be considered supervision. Okay, so independent, not in the room, supervision, in the room. The instant that we feel like we need to put our hands on Betty to help guide her or help her be more steady or more safe, feel like, uh-oh, we need to get our gait belt around her and hold on to the gait belt because she's looking a little unsteady today, then that would be the threshold for limited assist. So limited assist is defined as the patient is highly involved in the activity and staff assistance is required to provide guided maneuvering of limbs, no physical support or lifting is given. So it means we're just touching them, guiding them, but not actually using our muscle power to bear their weight in any way. So that would be considered limited assist. The instant that you have to start bearing her weight in any way, so for example, if you've got your gait belt around her, you thought maybe she looked a little unsteady, she goes to transfer and she starts to fall backwards. And we use the gait belt and we help her regain her balance so that she doesn't fall. That would be considered extensive assist, even though it's not a whole lot of assistance, but it's, if we weren't there to assist and use our muscle to help her regain her balance, then she would have had a fall. So we consider that extensive assist. And extensive assist is defined as the patient is involved in activity and staff assistance is required to lift, partially lift, and or support the weight of the patient's limb or body or weight-bearing support. So when you're thinking about limited assist as being touching, as soon as you have to use your strength to assist, then that's the threshold that it becomes extensive assist. Okay? Then the next level is total dependence. So at some point during the care that you're providing, Betty stops helping you at all, then that would be considered total dependence. And that's defined as the patient does not help, therefore full staff performance is required each time. So, for example, we needed to assist Betty because she lost her balance and we helped her regain her balance. Now we're working with her to transfer over to the chair. Well, she gets up, she starts to turn, you're providing a little bit of support, which would be considered extensive assist. Then her knees start to buckle and you have to grab on with both hands and help lift her the rest of the way to the chair or else she's going to fall to the floor. At that point, she stopped helping you at all, and that becomes total dependent. So the session went from independent all the way to total dependent within that given time frame. So as you're thinking about the care that you're providing and what Betty is doing while you're providing that care, before you walk in the room, she's independent. As soon as you have to put your eyes on her and offer her oversight and encouragement, it becomes supervision. As soon as you have to put your hand on her, it becomes limited assist. As soon as you have to bear her weight in any way with your muscle power, it becomes extensive assist. And as soon as she stops helping you, it becomes total dependence. So, and then each time you work with somebody, as you're going through this list of self-performance, you're always going to only count the lowest level or the highest level of dependency. So meaning, if briefly this morning Betty required extensive assist, but the rest of the day she was supervision. But because this morning she required that extensive assist, she's extensive assist for the whole shift. So you're counting that highest level of dependency. Yes?
So what does our stand-up lifts, what are they considered? Because they have to be able to hang on and they have to be able to stand.
Yep, and we have
but we lift them.
Yep, we have an example of that, and we'll go through that later. But you would consider that extensive assist supportive one. Yep. Yes.
Setup. What if you have to set somebody up, but, in other words, they wouldn't be able to do it if you didn't set it up,
Mm-hmm.
but if you set it up, they can do it by themselves.
Correct. So then you could confidently record that as independent with setup help under the next area, support provided.
Ah,
Yep.
okay.
So that's a perfect segue into support provided. So when you code 0, that means no setup or staff assistance. So Betty's able to do everything without any support from you at all. As soon as you have to provide equipment, provide, so a good example would be, if you're setting up their meal tray and you're cutting up the meat, opening the packages, that's considered setup help, even though she can feed herself, all the way. So you would code that as independent with setup help. Or, for example, and we've got some of these examples later on, if a gentleman has to use the bathroom and he typically will use his urinal while he's in bed, but he left his urinal sitting over there on the bedside table that he can't reach, he calls you in, you go in, give him his urinal, and then you leave and he takes care of his own bathroom. That would be considered independent with setup help. And then as soon as you have to provide physical assist, then you would have to determine whether it's one person or two persons. So again, 2 is one person physical assist, 3 is two person physical assist, and then 8 would be that the ADL activity didn't occur during that period. Okay? All right. Some important coding tips to remember, and these are the first page of the Betty manual. You want to code the actual assistance provided. You want to code for the most support provided. You don't want to code for the assistance that the patient should be receiving according to the care plan. You want to code what actually happened. So oftentimes I've run into situations where a C.N.A. would code that the person was limited assist of 1 when they actually performed at extensive assist of 1. And if you ask the question, why was that? Well, that's what the care plan says that they need to be. Well, that isn't exactly what happened. So regardless of what the care plan says, you want to do what actually happened. And the reason being is this is for the most accurate care plan. Because if you continually are seeing Betty start to need more and more extensive assist, then that will need to be taken into consideration by the whole team, which means the doctor, the nurses, the social worker, activities, therapy. Everybody will look at that and say, oh, she's requiring more assistance. We need to have the doctor look at her meds. We need to have nursing modify the care plan. We need social work to talk to her to see how she's feeling. And we need therapy to work with her to be able to physically improve. So a lot of decisions get made based on how accurately you're reporting your ADLs. And then the last thing here is you don't want to count assistance that family or visitors provide. They're often not going to have the judgment that we have in regards to how much assistance is required. They're just going to do for the patient, so or for their family members. So that wouldn't necessarily count towards what we count on our assessments. Okay. Any questions about those tips? All right, so let's define the 4 ADL areas, and this is key. If you think about the self-performance and the different definitions and the thresholds between each, you need to know how to apply those to the ADLs that you're assisting with. So defining the 4 ADL areas and understanding these definitions will help you then apply what it is that you're doing in terms of assistance and how the patient is performing. So the first one, bed mobility, is how the patient moves to and from a lying position, scoots up in bed, turns side to side, and positions body while in bed or in a recliner or other type of furniture that they sleep in. Even if they're taking a nap in the afternoon and they sleep in the recliner, you would code that for bed mobility. So each one of these 4 different areas of bed mobility needs to be taken into consideration as you're looking at the patient's performance and the assistance that you're providing them. For eating, it's how the patient eats, drinks, regardless of skill, does not include eating or drinking during med pass, and does include intake of nutrition by other means such as tube feeding, total parenteral nutrition, IV fluids administered for either nutrition or hydration. So those are the things that we need to consider for eating. Transfers is how the patient moves between surfaces, to and from the bed, chair, wheelchair, and to and from a standing position. And it does exclude to and from the bath or toilet, which are covered under toileting and bathing. And toilet use is how the patient uses the toilet room, commode, bedpan, or urinal, transfers on and off the toilet, cleanses self, changes their pad, manages ostomy or catheter, adjusts their clothing, and does not include emptying of the bedpan, urinal, bedside commode, catheter bag, or ostomy bag. So if all you're doing is emptying, then you wouldn't take that into consideration. Okay, any questions about the definitions of the 4 areas? Okay. Now let's move on to examples of setup help. So each one of the 4 ADL areas, we have an example of what you would code as setup help. So for bed mobility, handing the patient the bar on a trapeze and raising the half rail on the bed so that the patient can help themselves sit up and move to the side of the bed, that would be considered setup help. So if you did nothing more than go in, give them the trapeze, lift the side rail, and they did everything else, and even if you walked away and were out of the room while they did that, it would be considered independent with setup help. If you stood there to make sure that they were okay while they were doing that, it would be considered supervision with setup help. Eating, if you cut up the meat or open containers at meals, give the patient one food item at a time if that's the way they best were able to eat. Those would be considered setup help. And you know, for most people, when we serve them their tray, I don't know how it goes here at Pine Ridge now that you're in the new facility, but most places, if you're giving them a tray and you're getting everything set for them, and you're opening their containers and taking all the packages away and stuff like that, that would be considered setup help, even though they're able to do everything else. And then if you walked away and they went ahead and ate their meal, then you would code that as independent with setup help. If you had to sit there to make sure that they could eat, and if you needed to cue them through their meal a little bit, then that would be supervision with setup help. Transfer, and this one gets missed a lot. And this one was one that was kind of an aha moment for me. I'm like, oh yeah, we don't ever think about that. But if a patient is independent in their wheelchair mobility, they get around the facility everywhere they go, usually they transfer to and from other chairs without any assistance, but we have to watch them to make sure that they lock their brakes, because they're at risk for falls if they forget to lock their brakes. So we're watching Betty, and she's going over there to get into the chair in the activities room, and we see, oh, she's getting ready to transfer without locking her brakes. We go over there and say, you know, excuse me, Betty, wait just a second, let me help you, and then you lock the brakes for her and you walk away and she transfers. That would be considered supervision with setup help, because we were observing her, we provided cues, and we locked the brakes. So that's supervision with setup help. And then toilet use, if we hand the patient the bedpan or urinal, or place the articles necessary to change their ostomy if they have a colostomy, and they're able to do everything except we just need to set it up for them, that would be considered setup help as well. Any questions about those examples? Okay. Any examples you guys have that you're curious about that sound like setup? Oh, okay. All right, let's go into talking about some common coding errors. So first thing, all tasks of the ADL function are not assessed before coding that performance and not capturing the most dependency within the given area. So this is what I was talking about in regards to understanding all of the areas of the definition of each ADL and taking those into consideration before you code. So the example here is the patient is able to roll side to side in bed with use of the side rails, so it's coded 0 for independent, without assessing their ability to scooch up in bed, sit up from lying, or put their feet in and out of bed. So if all we did was code because they rolled side to side, then we've missed other areas of bed mobility. So if we needed to support them while sitting up, lift their legs out of bed, and we're coding them independent because they rolled side to side, what should that really be?
Helping.
So you're providing weight-bearing support
Right.
by helping them sit up and lifting their legs.
Yeah.
So it's extensive assist. So we may inadvertently miscode that, and that would create an error in how we care plan for that patient. Another example in toileting, the transfer to and from the toilet must be assessed when coding toilet use, in addition to clothing adjustment, donning of the brief, cleansing, and catheter care. So if all we did was code the transfer, we missed all the other areas of the definition of toileting. Not coding for one-time issues. So loss of balance while transferring and bearing the patient's weight during the transfer. So typically Betty is just supervision for a transfer. We stand there and we watch her transfer. But today she's looking a little unsteady, so we think, well, we better put her gait belt around her just in case. And so then she's really looking unsteady, so we put our hands on the gait belt. It goes from supervision to limited assist. Then when she goes to transfer, she starts to stumble and lose her balance, so we hold her a little tighter, keep her steady, becomes extensive assist. So it goes all the way through. And if that happened just once in the morning because she was a little groggy after she got up, had a bad night, then the rest of the day she's supervision, we still have to code that extensive assist for the day because that's what she required first thing in the morning. Loss of balance while sitting up in bed and bearing the weight of the patient's trunk. So how often does this happen where a patient goes to sit up, and typically they can do it, no problem, we just supervise to make sure they're okay, but they go to sit up and they start to fall back, and we catch them from behind and we help them the rest of the way. If we coded that as supervision, then that would be an error. It actually was extensive assist. Supporting the patient's weight during bed mobility. So now we've got her sitting up, we did extensive assist, now she's not feeling right, so she can't quite get her legs over the side of the bed. So we cup our hands under her calves and we help lift her legs over the side of the bed. And again, that's considered extensive assist. And then 2 people pulling the patient up in bed. So if Betty is having trouble scooting up and she's laying on a draw sheet, so you call in your partner on the unit and you both come in and scooch her up in bed, we'd have to code that as 2-person support. And if it would depend on if she was helping you a little bit or if she wasn't helping at all, whether you'd code that extensive assist or dependent. Okay. Now, let's talk about peer pressure. I don't know if you guys ever experienced this here. Some places experience it more than others. It just depends on the teamwork of the people that are working at the particular facility. But oftentimes, especially if a C.N.A. is newer and maybe just recently graduated with their certification, and they don't have a lot of experience at coding. So they come in and they're coding the way that they think they should code based on what they were just taught on their orientation. But a more experienced C.N.A. that's been around for a while, worked at this facility for a long time, knows all the patients really well, says, why did you code that person that way? They're always limited assist. But you know that you just experienced extensive assist based on what you've just recently been taught. So at that point you feel pressure to change it because this person's more experienced, they're here to guide you, and so you think, well, I must have misinterpreted something. so I change it to limited assist. If you know, based on what you're learning today and what you know from your experience, that that's the way that you should code it, and somebody's pressuring you to change it, definitely want to get that resolved. Talk to a nurse manager or an MDS coordinator, somebody that can help you decide what is the right thing to do.
Isn't it true that you basically want to code what happened on your shift? Because on his shift, the patient might not need it that extensive, but
Exactly.
with me, they did.
They did, yep.
So I'm
for
gonna
whatever
code it
reason.
how my shift was.
Exactly, yep.
Okay.
Yep, exactly. So, yeah, so don't ever feel pressure to do something that you know is different than what you experienced with that patient. Another thing that happens, especially if you're doing pen and paper coding or charting, is everybody has a busy day from time to time. I'm sure every day is a busy day because we got a lot of patients to take care of, and you forget to keep track of what you did. Like, it's end of your shift, you got to code everything, and you're like, I don't remember what I did with that person. That was 15 patients ago. So if you don't have a good system of tracking, what you should be coding, then there's going to be the tendency or the pressure to feel like you just look back at what they did in the last shift, and that's good enough for now. So you definitely don't want to do that because that lends to inaccurate coding. So always have a good way of keeping track and knowing exactly what you should code for each patient.
And then we need to do it at the end of our shift, really.
Yeah, because
you need to be able to see what they've done over the course of the whole day.
yep. So they may, if you did all of your charting, midway through your shift, and then something happened later in your shift that they needed more assistance, then you'd have to go back and change it. So you're creating more work for yourself. And then oftentimes, the patients that you're working with are also in therapy, and therapy will give you instructions as to how to work with this patient to help facilitate them to their optimal level. But therapy language is different than the MDS language that you're following. So they may say, this person needs, mod assist for their transfer, and just contact guard assist to get to the toilet. And you're like, ooh, how do I code that? Because it's different. The language is different. So never be afraid to clarify or ask questions. What does that mean? And I always encourage the therapist to, when they're working with the staff, is to use the MDS language. This person needs extensive assist. This person needs limited assist for their transfers. But just know that everything that the therapist's language is different only in the limited and extensive assist. Independent, supervision are all the same. Limited assist, therapy documents it as contact guard assist. Just means that we're touching to steady them. And then extensive assist incorporates 3 different levels in therapy: mid, mod, and max. And the mid, mod, and max are just percentages of how much assistance we're providing. But it's all extensive assist. So if they say mid, mod, or max, just that that's extensive assist. And dependent is dependent. So
That's where we're running into a difference too between therapy, because we do have one resident right now that we go by the Cardex of how the lifts are supposed to be used, how we're supposed to be lifting them. But therapy's doing it different than what we're doing, because they can lift, we can't.
well, and there may be differences in what therapy's doing versus what you're going to be doing, because the therapists are trained at facilitating that patient to the highest level possible. So that's what we're going to do. You guys need to do what you need to do for the best, for the good of the patient. So if you need to do more assistance than what we're providing, that's okay. And part of what's going to be happening, particularly on the skilled unit, is that the therapists the patients are going to come in at a much lower level than their prior level of function. And the therapists are going to be working with them to help build up to their previous level of function, and we're going to try to optimize their abilities on a day-to-day basis. What you're going to be experiencing is, after the patient has already been through their therapy and they may be fatigued, they may need more help from you than the therapy did. So what I recommend doing is looking at what therapy is documenting and what you're documenting as the caregivers. And the point where what therapy is seeing and what you're seeing, when it comes closer and closer together, that means that the skills that the patient is learning are more sustainable throughout the day, and that means they're getting closer and closer to being ready to be discharged back to home. So, so that's an indicator that the interdisciplinary team can look at and see, you know, is this person going to be able to go home and sustain their functional abilities all the way through a 24-hour period. And if they can't, which is what you'll see and what you'll document, you know, if you're working with them at 10 o'clock at night and they're not able to transfer the same way they do for therapy at 9 o'clock in the morning, then we know that person's not ready to go yet. So that's another reason why it's very, very important that you guys are recording exactly what you see and what you do, because we're going to use that as a comparison and be able to look at that and say, yep, this person's ready, or nope, they're not ready yet. Does that make sense? Okay. All right, let's talk about some best practices to keep accurate coding of late loss ADLs up. Doing just what we're doing right now, providing training and ongoing training, and that's why we're videotaping today, is so that this training can be duplicated for people in the future as new C.N.A.s come to work, or as refresher courses for current people. A good practice to get into is, especially if you have a new person coming to work, is to shadow them to see, are they actually coding the way that they should be by what they're actually performing. So looking at them, validating their ability to code it accurately will help make sure that we've got coding as accurate as possible. Establishing a training program for new hires, which is what this video is going to help support us in doing. Do you have C.N.A.s that are considered mentors in your group of C.N.A.s, or somebody that you can go to and bounce ideas off or questions about coding? Nobody you can think of?
There's not a formal system for that at this time.
Okay, all right. And that's something to consider for the future, is if there's one person that works on each shift that's been validated to correct most accurately, then that could be the go-to person to say, hey, I got a question, you know, can you help me out? And, you know, of course, this reference manual is going to help you answer those questions, but if you've got somebody to talk to, that also helps. And then if you do decide on having, you know, C.N.A. mentors or somebody that is a go-to person, validating that they're actually coding correctly, so that when you ask them questions, then you know that you're going to get the right answer from them. Doing quarterly refresher trainings or quizzes or things like that that help keep your mind fresh on how to accurately code. Using this reference manual for visualization and easy reference of how to code is also a very good practice to get into. Asking questions if you're not sure. Don't, you know, as they say, you know, there's no stupid question, only stupid answers. But if you're not sure, you know, ask a question. Find somebody that does know the answer so that you can code accurately for the benefit of the patient. The patient needs to have that information in their record so that we can provide the best care possible. And then the one thing that I find most helpful is for you know, the C.N.A.s that are, you guys that are working on the floor and doing this every day. If something occurs to you that, you know, may be a better way of going about things, or something that would help you be more accurate in your coding, offering that suggestion to whomever your supervisor is, so that that can be taken into consideration. Usually the best ideas come from the people that do the work, because you guys are the ones that have to do it, and you guys know what works best. Okay. So let's take a look at the Betty manual, and let's go through how to utilize this manual to your best benefit. So again, like I said, the first page is the important coding tips to remember. These should be things on your mind all the time. You want to code the actual assistance provided. You want to code for the most support provided. You want to code what actually happened, and you don't want to code what family or visitors provided. The next page are the ADL definitions. The ADL definitions are color-coded, red, orange, blue, and green, and those correspond with a tab over to the side, so that if you want to look up how to code transfers, transfers are blue, you go to the blue tab, you flip back to the blue tab, and that takes you right to the transfers. Okay? And we'll go through some specific examples of each of the different areas and how to code. The next page is the actual definitions of self-performance and support provided for quick reference. And I just want to reiterate the thresholds between each of the performance areas. So independent, you're not in the room. As soon as you walk in the room, it's supervision. As soon as you touch the patient, it's limited assist. As soon as you use your muscle power to support the patient, it's extensive assist. And as soon as the patient stops helping you, it's total dependence. Okay? Now, let's look at how the examples are set up. Each one of the ADL areas has a visual, pictorial example, it has the definition, and then it has the actual coding. So in 3 ways you can see how to code that patient depending on what's going on. So I don't want to go through all of these examples, it would take up too much of your time, but I did want to go through some specific examples that I often get questions about. So the first one is on page 6, Extensive Assist Example B, and on page 8, Total Dependence Example B. So both of these situations look very similar. Betty's laying in bed with a draw sheet under her. 2 caregivers there preparing to scooch Betty up in bed. So one is coded extensive assist with 2-person support. The other is coded total dependence with 2-person support. So what's the difference between the two, and why would one be coded one way and one the other?
Where she's helping with her feet. She's positioning her feet, so she's gonna help put, when they get ready for she's gonna help.
Exactly. In extensive assist example B, the difference is Betty has her knees bent and her heels planted on the bed so that she can bridge her bottom up and reduce the amount of weight and the amount of friction on the bed, so that it would be a lot easier for you as the caregivers to boost her up into bed. In total dependence example B, Betty's legs are out straight and she has no intention of helping, so you and your partner there are going to have to lift her completely and scooch her up. So that would be considered total dependent. Okay, next example is on page 10. This is in eating. Limited assist and extensive assist example A. So 2 very similar situations here. Betty's sitting on the side of her bed with her bedside table there and her lunch tray, and she's feeding herself. One's coded limited assist, one's coded extensive assist. What's the difference?
She's just guiding her with the limited assist, but with the other one, she basically have to put the food up to her mouth.
Mm-hmm. Yep, exactly. So the way I look at this example here is the limited assist is at the beginning of the meal, extensive assist is at the end of the meal. So Betty's able to lift her hand to her mouth on limited assist. The caregiver just has to put her hand on her elbow to help guide her to make sure that she doesn't lift her elbow up. One of the things that I always look at as an occupational therapist is if somebody's feeding themselves, are they doing it efficiently with the least amount of energy? So if you try to feed yourself and you compensate by lifting your elbow to get your hand to your mouth, that's a very inefficient way of feeding yourself. It requires more energy. So to help keep her from fatiguing more quickly, put your hand on her elbow, That way her hand stays down, she can use her hand to mouth most efficiently. Extensive assist. Betty is fatigued now at the end of the meal. She can still hold her sandwich, but she can't get it up to her mouth. So the caregiver has to lift her arm to help her get her sandwich up to her mouth to help her finish that meal. So then that would be coded as extensive assist. Betty's helping because she's holding the sandwich, but you're providing extensive assist because you're lifting her arm up to her mouth. Okay, one more example here is on page 12, and this is extensive assist example D. And the scenario here is Betty's sitting in her bed with her bedside table and her tray, and she's eating, but it's coded as extensive assist. Why?
She has
Feeding tube.
supplements.
Yep, she's getting supplemental feeding through the feeding tube. So regardless of her skill level at being able to feed herself, if she's got a G-tube, regardless of how much she gets from the G-tube, it's always going to be extensive assist, and one for coded as 2 for one-person support. Now, if Betty was not able to feed herself, or she was NPO because she's not supposed to feed herself because she may choke, and she's getting all of her meals through the G-tube, then that would be total dependence with 2 for one-person support. Okay, now, there's not a real specific example in transfers that I wanted to go through, but I did want to talk again, because this is where most often the errors occur in coding self-performance. And it's because we just don't take into consideration those thresholds between the self-performance areas. So just to reiterate, when you're working with transfers, if you're not in the room and they transfer from their bed to their chair, it's independent. If you're in the room and they transfer, it's supervision. If you have to put your hand on them while they transfer or apply the gait belt and hold the gait belt, it's limited assist. And then if you have to lift with your muscle power to help her over to the chair, extensive assist. And then if she doesn't help and you have to totally lift, which I understand you guys don't do here, but if you had to, then that would be total dependence. Okay. One more thing. This goes to the mechanical lifts that were brought up earlier. If you're using a Hoyer lift, how would that always be coded?
Total dependence.
Total dependence with coded as 3 for two-person support. And it has to always be total dependence when you use a Hoyer lift because Betty can't help, because it puts her at risk for injury. If she were to hold on to the sling or hold on to the bar above and try to help lift herself while you're lifting her with the Hoyer, then she could potentially get injured. So we have to discourage her from trying to help if we have to use a Hoyer. That way, then she would be at less risk for injury. So that would be coded as total dependence for self-performance and two-person for support. And there always has to be 2 people there because one person has to manage the patient and the other person has to manage the lift. Is that how it goes here?
Mm-mm.
No?
Sorry.
No, we don't,
We always
we do it ourselves.
Oh,
We don't-
okay. So, you know, that may be something to talk about because typically if somebody's not there, even if it's just in case the patient needs assistance while they're being Hoyered, there usually has to be somebody there because while you're using the lift and maneuvering the lift, you can't be there with the patient to assist them. So typically it would be...
We got the handheld, we there with the patient in the hand thing ourselves.
Okay, so that may be different, but...
Maybe you need to watch us do it sometime.
Maybe. Maybe.
Yeah.
Because she has the handheld in the picture.
Yeah, we use the handheld
But
and
then
She has
Yeah.
it in the picture too when she's
Yeah.
so.
So it's typically the recommendation to have 2 people during a Hoyer lift. Now, during a, do you guys have a sit, you said you have sit-to-stand lifts. So a sit-to-stand lift, how would that be coded? How do you code that one?
the sit to stand.
Mm-hmm.
the extensive assistance.
Yeah.
Because
If it's
they-
doing the
yeah.
lifting instead of us.
Right, and they're using their, to hold on, so,
Right.
yeah.
So you're absolutely right, it has to be extensive assist and
Right.
it can't be dependent,
Right.
because if the patient is dependent and you're using that, then they're not able to push with their
Right.
legs, and you're placing them at risk for injury to their ankles, knees, and hips.
Right.
So, so they have to be able to help some, they have to be able to push and they have to be able to pull. So it would always be extensive assist, and that one could be assist of 1 or 2, depending on the individual. Okay. Now, let's do an example in toilet use. The example that I typically use is on page 20, limited assist example A, and on page 22, extensive assist example C. So these are two very similar situations again, but very different reasons why you would code one way and one the other. So in this situation, Betty's getting ready to go to the bathroom. She's using a walker, and she has a caregiver there to support her. In limited assist example A, all the caregiver's doing is managing her fasteners, so her belt, her button, and her zipper. From there, Betty can bring her clothing down, she can transfer to sit onto the toilet, she can do her own hygiene, she can stand back up, she can bring her clothing back up, and then the caregiver just has to help with the fasteners again. So that would be considered limited assist. We're not providing any weight-bearing support, we're just assisting with the clothing fasteners. Now, extensive assist, example C, same situation, Betty's standing at the toilet, caregiver's there, Betty's using a walker, except in this situation, Betty's not able to stand there without bearing her own weight on that walker. She can't take her hands off to manage her clothing and sit down. So the caregiver has to manage the fasteners, has to manage the clothing, and then has to guide Betty to the toilet. And then when we go to stand up, the caregiver has to bring the clothing back up and manage the fasteners while Betty's bearing her weight on the walker. So that's considered extensive assist. And the question always comes up, well, there's no real weight-bearing support there from the caregiver, so why would you code that extensive assist? And the reason being is if Betty were to take her hands off the walker, we would have to bear her weight, because she can't stand there without bearing her own weight. So because she has to bear her own weight, we have to manage her clothing. So then she can then sit down and use the toilet. So that is a weight-bearing component. Now, alternatively, we could have Betty manage her own clothing, but then we'd have to bear her weight, and that would be very unsafe for you and for Betty. So, so it's always better to have her bear her own weight using the walker, and then we manage the clothing. So that's where the weight-bearing component comes in with that one. Okay, any questions about any of the examples or any of the examples that you've seen that you want to talk about or clarify? Okay, well, then closing statement. On the last page of the Betty manual, code for the most support you provided during your shift, even if it only occurs one time. Okay, thank you very much.
Thank you.
Uh-huh.
That is-